Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on Tenofovir Alafenamide, or TAF, in pregnancy, featuring Dr. Milena Murray from Midwestern University College of Pharmacy and Northwestern Memorial Hospital in Chicago, Illinois. She'll take us through a case study of a patient on an ART regimen that contains TAF who becomes pregnant. She'll explore the data to support her decision to recommend the use of TAF in pregnancy. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Murray.
Hello and welcome to Key Decisions in HIV. Our topic today is considering Tenofovir Alafenamide in pregnancy. My name is Milena Murray, and I'm an associate professor of pharmacy practice at Midwestern University College of Pharmacy, the Downers Grove campus, as well as an HIV ID clinical pharmacist at Northwestern Memorial Hospital. Let's start out with a case study of a 30-year-old woman who presents to her regular HIV follow-up appointment and estimates that she is approximately 4 months pregnant. Up until this point, she has no prenatal care, and her HIV is well controlled on a regimen of dolutegravir with emtricitabine and TAF. The patient reports no adverse events, and she's currently not reporting any nausea. Her labs are listed on the right side of the slide. She has a robust CD4 count at 571, and her viral load is undetectable. So the question here is, do we need to change her antiretroviral regimen because she reports that she is pregnant? This table has recommendations from the DHHS guidelines for initial antiretroviral therapy during pregnancy. They are grouped into preferred, alternative, insufficient data to recommend, as well as not recommended. Each of the regimens also has restrictions dependent upon if there is a CD4 count or a pre-treatment HIV viral load cutoff. So our preferred NRTIs are lamivudine and abacavir, or emtricitabine with tenofovir disoproxil fumarate, or lamivudine with TDF or tenofovir disoproxil fumarate. TAF has actually moved into the alternative regimens now, so we can do emtricitabine with TAF or lamivudine with zidovudine. Looking at the INSTIs, dolutegravir is a preferred INSTI, along with raltegravir, and our preferred protease inhibitors are atazanavir with ritonavir or darunavir with ritonavir, noting that the darunavir should be used twice daily in pregnancy. Of note with the dolutegravir, use at conception or very early in pregnancy, the first trimester, has been associated with a small increase in neural tube defects. However, there has been sufficient data showing that this is small enough that a benefit-risk discussion should be had with the patient, and it is a preferred INSTI at this time. Looking more into TAF and pregnancy, there are changes that occur during pregnancy that may affect TAF disposition, and these occur during the absorption, distribution, and elimination stages. During absorption, there may be higher gestational transit time and cobicistat-mediated P-glycoprotein inhibition if it's given concomitantly with TAF. Pregnancy is related with an increased volume of distribution, decreased albumin and alpha-1 acid glycoprotein in the plasma, and likely this increases free TAF concentrations. On the elimination stage, there is an increased renal blood flow, GFR, creatinine clearance, and decreased placental P-glycoprotein. Brooks and colleagues analyzed TAF exposures during pregnancy and postpartum. This graph illustrates TAF area under the curve by the second and third trimesters, as well as postpartum. For all time points, the plasma TAF exposures during pregnancy were within the typical range for non-pregnant adults. This was done with the 25 milligram dose. Data on TAF exposure are also available from the Antiretroviral Pregnancy Registry. This registry collects pregnancy exposures to antiretroviral therapy and pregnancy outcomes. These data are from healthcare professionals prospectively reporting exposures prior to the outcomes of pregnancy being known. The registry collects maternal demographics, antiretroviral exposure by trimester of earliest exposure, and then the outcomes that are collected include live or stillborn infant, spontaneous or induced abortion, and any major structural or chromosomal defect. The registry requires a threshold of 200 exposures, which can detect a 2 or greater fold increased risk of overall birth defects. This risk was not present for TAF. A detailed review of cases did not identify a pattern of birth defects for TAF exposures, and the prevalence of birth defects in the first trimester was 17 out of 249 live births. This is an ongoing open registry, and outcomes will continue to be monitored. The Antiretroviral Pregnancy Registry also reports on the prevalence of major birth defects. The data available are listed in the table, and drug-specific birth defect rates are on the graph to the right. TAF is approximately 1/3 from the bottom of the graph. The prevalence of defects is plotted against the MACDP, or Metropolitan Atlanta Congenital Defects Program, and the TBDR, or the Texas Birth Defects Registry. There were no significant differences in birth defect prevalence overall or by trimester of exposure compared to both of these population-based surveillance systems. The IMPAACT trial compared the safety and efficacy of dolutegravir plus either emtricitabine and TAF to efavirenz with emtricitabine and tenofovir disoproxil fumarate, or TDF. Participants were antiretroviral therapy naive pregnant women. Currently, data through 50 weeks postpartum are available as an update to a previous analysis showing higher virologic suppression rates and less frequent adverse pregnancy outcomes with dolutegravir-based therapy. For the safety analysis, maternal and infant grade 3 or higher adverse events were similar across treatment groups. There were fewer infant deaths in the dolutegravir groups compared to efavirenz. In a post-hoc analysis of stillbirth or infant deaths, there were numerically fewer occurrences in the dolutegravir plus emtricitabine and TAF arm compared to the other two arms. There were 4 major congenital anomalies reported, 2 in the dolutegravir plus emtricitabine and TAF arm, and 2 in the efavirenz arm. The maternal virologic response was similar with combined dolutegravir arms compared to the efavirenz arm. Of note, virologic suppression was defined as less than 200 copies per milliliter at 50 weeks postpartum. The percentage of women with virologic failure at 24 weeks or greater during the study was lower for both dolutegravir arms compared to the efavirenz arm. Overall, the authors concluded that frequency of grade 3 or higher adverse events was similar across all arms through 50 weeks postpartum, with a higher infant mortality rate in a post-hoc analysis with efavirenz-based therapy. Virologic suppression was high and similar through 50 weeks postpartum between the groups. There was a significantly higher rate of virologic failure in a post-hoc analysis at 24 weeks or greater with efavirenz-based therapy versus dolutegravir-based therapy. Because the adverse effects were similar between all arms, including the TAF arm, and dolutegravir is safe and effective compared to efavirenz, it would be okay to proceed with the current therapy that is in our case patient. So for our key take-home points, current guidelines recommend TAF as an alternative agent during pregnancy. When we look at plasma TAF concentrations during pregnancy, they are within the typical range for non-pregnant adults. There are no TAF dose adjustments that are needed or necessary during pregnancy, and the available data suggests that TAF is safe during pregnancy. Thank you for joining us today for this Key Decisions in HIV Care topic. There are more medical minutes and podcasts with expert faculty, clinical thought commentaries from physicians and patients, as well as patient education sheets that are available to print and share. And all of these resources are located online at clinicaloptions.com/HIV.
Thank you to Dr. Murray, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.